Right, welcome everyone. The standing room only at the Grand Rounds today. To get everyone to sit down, particularly professors of diabetes need to sit down for the diabetes talk. Welcome to Grand Rounds today. So Endocrinology are presenting, so great pleasure to invite Ritoo Chowdhury, who's an Advanced Trainee in Endocrinology and from my old stomping ground in East Melbourne, so from the Box Hill Eastern Melbourne network. So we'll be presenting on the newer agents in type 2 diabetes, which is particularly relevant given the type of food we've got outside the Grand Rounds today, which is also an advertisement to come to Grand Rounds because there is very delicious food. Ritoo, go ahead.
All right. Hello, everyone. Thanks for the introduction, Ashwin. So today, as mentioned already, we'll be speaking about the newer agents in type 2 diabetes, something that's quite relevant, I guess, because of all the advances that have taken place in the last 30 years and even more so in the last 10 years. Is it still there? You can't hear me. Hello? Yeah. Okay. So just briefly, some data about diabetes worldwide, including both type 1 and type 2 diabetes. 2021, the International Diabetes Federation published some data about the prevalence of diabetes, and at that time it was mentioned that about 1 in 10 adults have got diabetes and about 1 in 2 adults are undiagnosed, making the prevalence more like 1 in 20 that we're actually aware of. And given such a wide number of people being affected by this condition, the global health expenditure is about 11.5% just attributed to diabetes and its complications, and 6.7 million deaths per year due to diabetes. So here we could see the predicted prevalence of diabetes over the next 20 years. We've also got data from 2000 as well. There was clearly an increase over 2000 to 2021, and that increase is expected to continue on to 2045, where the prevalence is expected to be at about 784 million. So this is the global diabetes incidence, and purple is represented by represents Australia, and again the expected increase in diabetes is about 27%. So we all need to know about diabetes. In terms of the prevalence in Australia at the moment, it's about 1 in 20 people have diabetes, both type 1 and type 2. And as age increases above 75, this increases to about 1 in 5 people with diabetes. So before we go on about the newer treatments in diabetes, I just wanted to give everyone a bit of a history lesson so we can truly appreciate how far we've come. So firstly, the UK prospective diabetes study, which was actually published in 1998, so not too long ago. I think most people were born at that stage. Essentially, it was a trial where we were first able to provide evidence that tighter glycemic control actually led to an improvement in microvascular complications. So basically they looked at 4,200 patients with newly diagnosed type 2 diabetes, and they were either in the intensive group where they received insulin, sulfonylurea or metformin if they were overweight, or they were just managed conventionally with just diet and only had drugs started if the fasting blood glucose was above 15. So by the end of the trial, the HbA1c was 7% in the intensive group and then 7.9 in the conventional group. And basically at the end of it, they found that there was a reduction in microvascular endpoints in the intensive group, and also a reduction in diabetes-related deaths and mortality, but this was not, the study wasn't sufficiently powered for that. So 10 years later, we found that this trial was followed up for another 10 years, and basically it was found that there was a legacy effect after the initial tight glycemic control. So there was no effort made to continue on the drug therapies that they were on during the initial trial, but within 1 year, unsurprisingly, the HbA1c difference between the two groups were lost. So what they found was, despite this loss of difference in the HbA1c, there was still an improvement compared to the conventional group in terms of the microvascular complications, and for the first time, macrovascular complications as well. So the myocardial infarctions were 33% lower in the metformin group and 15% lower in the sulfonylurea insulin group. Death from any cause as well was lower in both groups. So you can see this data represented here showing that that was a significant difference. So in 2018, Rajani and his group presented on the risk factors, mortality, and cardiovascular outcomes in the type 2 diabetes patients. So this was a large cohort study based on 270,000 patients from the Swedish National Diabetes Register. And basically they matched these patients with 1.3 million controls based on age, sex, and country. So the risk factors that they looked at were 5 in total. So HbA1c above or equal to 7%, elevated LDL greater than or equal to 2.5 millimoles per litre, albuminuria, current smoking status at the time of entry, and elevated systolic blood pressure greater than 140 or greater than 80 diastolic. The outcomes they looked at were death or an increase in myocardial infarctions, stroke, and hospitalisation from heart failure. So this represents the hazard ratios based on the ages and the number of risk factors that they do have. So in panel A, you can see that the excess mortality in relation to the increasing number of risk factors. So down the bottom here. So as you go down each group, there's an addition of risk factor as you go down, and purple represents 80 and orange represents ages less than 55. So this is the control group here. And as you can see, with each addition of risk factors, the hazard ratio actually increases in terms of excess mortality. And the same thing can be seen with the myocardial infarctions. And what they tried to show was that with the patients with type 2 diabetes, if they had no risk factors, they had a similar hazard ratio to the group, the control group as well. So similarly here in terms of myocardial infarctions, and then here in terms of strokes. But when it came to heart failure, however, the same sort of rule didn't apply. So in terms of the type 2 diabetes therapies and the sort of timeline over the last 100 years or so, a lot has happened, especially in the last 20 years. But 1922 is when we first actually had insulin first administered to a human. And then 30 years later, the sulfonylureas became commercially available. And then a few years after that, metformin finally was available to countries outside of the USA. And then another 30 years later or so, the first alpha-glucosidase inhibitors were available, so acarbose. But given the significant side effects which were not tolerated by patients with flatulence and bloating, this is actually not really used very often at all anymore. The year after, the first thiazolidine was available, and again, we don't prescribe this anymore given the risk factors of risk of heart failure and bladder cancer as well. And then moving forward another 10 years after that, so 2005, we had our first GLP-1 receptor agonist, also known as exenatide, and the first DPP-4 inhibitor, which was sitagliptin. And then 8 years after that, the first SGLT2 inhibitor, canagliflozin, was available. So this represents the rough sort of HbA1c changes as per the different drug classes. Obviously, you know, when these studies are done, it can be in addition to other drugs and not just standalone therapy. But what I want everyone to take away from this is that with each drug class, the HbA1c reduction is roughly 1%, give or take a little. So in particular, what I want to highlight is that GLP-1 receptor agonists are better than just dropping the HbA1c by 1%. So with dulaglutide and semaglutide, we see a HbA1c decrease of about 1.35 to 1.77%. And then with the DPP-4 inhibitors, the HbA1c reduction is more like 0.5%. So I'm sure you're all wondering why the topic is poison apple. So I'll speak about the apple part first. So fluorizin is a compound that comes from the root bark of apple trees. And essentially, this is where SGLT2 inhibitors were derived from. Now, back in 1933, fluorizin itself was tested in a small group of people. And what they found was that it does increase your glucose in the urine, and it also lowers your blood glucose. But the effects were not limited to the kidney. So it also inhibits glucose absorption in the gut, and it also interferes with glucose transport in other parts of the body. So not something that we use in humans. And what they found was that fluorizin actually inhibits both the sodium glucose cotransporter 1 and 2. And then eventually SGLT2 inhibitors came about. So we'll speak about our first case today first. So 58-year-old lady who came in with a late presentation of a STEMI with poorly controlled type 2 diabetes, HbA1c of 13.7% in March when she presented last year. She already had complications of peripheral neuropathy in addition to her ischemic heart disease and microalbuminuria as well. Otherwise, she has obesity with a weight of 179 kilograms. So this lady, when she came in, was only on metformin MR 500 milligrams twice daily and glucoside MR 60 milligrams daily. She had an echocardiogram as an inpatient, which showed an ejection fraction of 40 to 45%. And given that she had a HbA1c above 13% and her blood glucose levels were above 15 as an inpatient, she scored an endocrine consult. So before we go on to a bit more about the SGLT2 inhibitors, I just thought we'd talk about the mechanism. So firstly, the sodium glucose cotransporter 2 is responsible for reabsorbing 90% of the glucose that it would otherwise be excreted by the urine. The sodium glucose cotransporter 1 is responsible for 10% of this reabsorption process. The SGLT2 inhibitors essentially block that initial receptor we spoke about, SGLT2, and thereby getting glucoseuria. So the SGLT2 inhibitors leads to a weight loss of approximately 2 to 3 kilograms and a reduction in HbA1c that I've mentioned already. It also causes a decrease in blood pressure and also acute diuresis as well, which is maximal for the first 3 days and then returns to baseline with approximate volume loss of about 7%. It also has favorable effects on arterial stiffness, vascular resistance, visceral adiposity, and albuminuria. So we'll talk about the EMPA-REG trial first. So this was published in 2015 in the NEJM. So this looked at 7,020 patients and they were double-blinded and it was a double-blinded randomized controlled trial looking at placebo versus 10 milligrams of empagliflozin versus 25 milligrams with type 2 diabetes patients at high cardiovascular risk. The primary outcome they looked at was a composite of death from cardiovascular causes, non-fatal myocardial infarction, and non-fatal stroke. And the key secondary outcome was a composite of the primary plus hospitalization for unstable angina. So this is the trend of the HbA1cs in the different groups. So there was a reduction in HbA1c by 0.24% in the 10 milligram group and a reduction by 0.36% in the 25 milligram group. So there was a 14% reduction in the primary outcome, which, as mentioned, was a composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke. There was also a significantly lower risk of cardiovascular death in the pooled empagliflozin group and a 35% risk reduction in hospitalization for heart failure in the empagliflozin group as well, the pooled empagliflozin group. There was also a reduction of 32% in death from any cause in the empagliflozin group. So their conclusion was that the addition of empagliflozin to standard care in patients with type 2 diabetes and high cardiovascular risk does reduce cardiovascular morbidity and mortality. Moving on to the EMPA-Kidney trial, which was published in NEJM earlier this year. So this basically looked at the effect of empagliflozin on the progression of kidney disease. So again, this is a randomized controlled trial with 6,000 patients, and this time 54% of patients did not have diabetes, and they compared placebo to empagliflozin 10 milligrams daily. So the groups they looked at were an eGFR of 20 to less than 45 or eGFR 45 to less than 90 with an urine ACR of greater than or equal to 200 milligrams per gram. So the primary outcome they looked at was kidney disease progression or death from cardiovascular cause, but they defined kidney disease progression as end-stage kidney disease with the commencement of dialysis or receipt of a transplant, a sustained decrease in the eGFR to less than 10, or a sustained decrease from baseline in the eGFR of at least 40%, or death from renal causes. This key secondary outcome was a composite of hospitalization for heart failure or death from cardiovascular causes, hospitalization for any cause, or death from any cause. So here are the results of the primary composite outcome of progression of kidney disease or death from cardiovascular cause. And over a median of 2 years, the kidney disease or death from cardiovascular cause occurred in 13.1% in the empagliflozin group versus 16.9% in the placebo group. And this represents the hazard ratios for the primary outcome in key pre-specified subgroups defined according to the baseline characteristics. So you can see here that diabetes mellitus, whether it was absent or present, was both beneficial in terms of the primary outcome, although it was slightly more beneficial if they did have type 2 diabetes. Otherwise, things to look at here is also the fact that with a higher EGFR being greater than 45, there was a better effect on the primary outcome with the empagliflozin group. They did also use the EGFR of 20 to less than 30 as a group that they looked at, and the use of empagliflozin was still beneficial. So we actually use a cutoff of less than 30 in terms of EGFR for glycemic management. And then in terms of the urine ACR, the lower the urine ACR, i.e. less than 30, the less of an effect that empagliflozin had on these patients. So the change from baseline in EGFR, as you can see here, the orange is represents empagliflozin and blue represents the placebo. There is an initial acute decline in the EGFR for the empagliflozin group, but this then stabilizes and comes out and is actually, by the end of the trial, the EGFR was on average higher than in the placebo group, where there's a steady decline in the EGFR. So the conclusion was that empagliflozin led to a 28% decrease in the risk of progression of kidney disease or death from cardiovascular causes than that with placebo, with no major safety concerns. Hospitalization for any cause was also 14% lower, and treatment was effective regardless of their diabetes state. And here you could see a summary of the renal composite outcomes with SGLT2 inhibitors, and the hazard ratios were always lower in the SGLT2 inhibitor groups. So the proposed mechanism for SGLT2 inhibitors and how it reduces the risk of heart failure and progression of kidney disease is not well understood, but one of the proposed mechanisms is that the SGLT2 inhibitor causes glucosuria and therefore with a loss of calories induces a fasting-like paradigm as well as a hypoxia-like paradigm, subsequently then activating AMP kinase, HIF2 alpha and SIRT1, and then downstream this results in a decrease in intracellular sodium, a reduction in inflammasome activation, and increased mitochondrial stability, as well as decreased oxidative stress, which ultimately results in a reduction in cellular stress and dysfunction and death. So in terms of adverse effects, we all need to be aware of these because it will obviously impact your decision as to whether you start someone on therapy with SGLT2 inhibitors or otherwise change their therapy. Genitourinary infections is a big, it's a fairly common side effect that we all should be aware of. Approximately 10 to 15% of women are affected with vulvovaginal candidiasis, but it is also important to check whether your male patients have candidiasis and also to check whether or not they actually know what candida is. Otherwise, UTIs, pyelonephritis, and Fournier's gangrene can also be seen in this group. In terms of hypotension, given that it does cause a diuresis, it's important to check in with your older patients and patients on multiple antihypertensive agents or other diuretics to see whether they're developing symptoms of postural hypotension. And if they are, it might just be a matter of changing the other antihypertensive medications that they're on. In terms of acute kidney injury as well, all the patients starting SGLT2 inhibitors should have a baseline EGFR to start off with, and then this can be reviewed in another 2 to 3 weeks to see whether there has been a drop in EGFR. A drop in EGFR of about 30% can be seen, and anything more than that should prompt cessation of therapy. There have been some studies as well looking at cadagliflozin and their incidence of fractures, and there has been some studies that suggest that the risk of fractures may be higher in the cadagliflozin group, but we don't use cadagliflozin in Australia and it's not available. So moving on to amputations as a side effect as well, there have been some randomized controlled trials about which showed that the risk of amputations was approximately 2 times higher with the use of cadagliflozin, but there have been some analyses with other SGLT2 inhibitors and the same effect hasn't really been seen, but something of course to be aware of, and as more data comes out, I'm sure we'll have a better idea of the relationship with amputations and SGLT2 inhibitors. So euglycemic ketoacidosis scores its own page, something that in the inpatient setting, of course, is something that we all should be aware of. There's often a delay in recognizing the fact that a patient might have euglycaemic ketoacidosis because of SGLT2 inhibitors, and this is generally because the blood glucose is not elevated as you would see in DKA. The other thing to be aware of is that brand names can sometimes be confusing, so important to take a good medication history and document the last time they actually had an SGLT2 inhibitor. If the patients come in obviously unwell, not eating and drinking, vomiting, septic, withhold the medication and make sure that you check ketones on a daily basis at least for 3 days after ceasing SGLT2 inhibitor. And otherwise, if they're also going for surgery, when you're planning for surgery, make sure that the patient is aware they need to stop the SGLT2 inhibitor for 72 hours prior to the surgery. And this is, obviously different to the usual oral hypoglycemics that you advise to just stop on the day. So once patients are eating and drinking and close to discharge, they can recommence in the SGLT2 inhibitors. So in terms of precautions, anyone who's had a prior DKA, avoid SGLT2 inhibitors in future. Patients with type 1 diabetes or pancreatic insufficiency, the TGA actually does not approve SGLT2 inhibitors in these patients, so obviously should be avoided. Patients who are planning to go into ketogenic diets should be advised as well not to take SGLT2 inhibitors. And then in patients with eGFR less than 30 with type 2 diabetes, we don't prescribe SGLT2 inhibitors, and we know that there's a less of a glycemic benefit in these patients as well. So in terms of otherwise frequent bacterial UTIs or genitourinary infection as well, this should probably prompt reconsidering this drug in these patients. So obviously we need to weigh up the benefits and risks in all of our patients. So with the patient that I discussed earlier on, she was actually in discharge on empagliflozin 10 milligrams daily, linagliptin and opticillin in addition to her original medications. 3 months later, she had a HbA1c of 10.1% from 13.7% earlier, and her weight decreased to 158 kilograms with the addition of significant lifestyle modifications. She was planned to start semaglutide later after her optometry review. 3 months further down the track, her HbA1c was even better at 7.2%, with a further decrease in her weight of 149 kilograms. Gliclazide was ceased, and then in December, another 3 months later than that, her HbA1c was 6.7% with a weight of 146.1, and her opticillin dose had started to be dropped back. So there you can see the changes in her weight and HbA1c. So the change in weight is quite significant in this patient, and I think that's largely due to her lifestyle modifications rather than the SGLT2 inhibitor. So in terms of the next part of the talk, the GLP-1 receptor agonists. The reason why it's called poison ivy is because GLP-1 receptor agonists originally came from the synthetic version of salivary protein found in the Gila monster. And this is approximately 50% identical to human GLP-1, and it binds to the human GLP-1 receptors on beta cells in the pancreas, and it's resistant to DPP-4 inactivation. So the second case of the day is a 39-year-old gentleman from the Obesity Management Service who has class 3 obesity and type 2 diabetes, BMI of 45.5 and HbA1c of 9.3% on initial assessment. He was only on metformin 1 gram twice daily when he was first seen in February 21, and then on review in September 21, he'd made an attempt to increase his physical activity to 10 to 15 minute walks per day, and his HbA1c dropped to 8.2%. He was commenced on semaglutide at this point in time. So this is just a diagram of the enteroendocrine cells, which secrete glucose-dependent insulinotropic peptide, also known as GIP, and the GLP-1, which is the glucagon-like peptide. This just shows the mechanism of action of the GLP-1 receptor agonist. So firstly, I'll talk about the endogenous incretins we have. So after the ingestion of food, we have a secretion of the incretins GLP-1 and GIP, which then acts on the pancreas to increase insulin secretion with peripheral increased glucose uptake, and then a decrease in glucagon secretion, which causes a reduction in hepatic glucose production. And then ultimately, this causes a reduction in blood glucose. DPP-4 inhibitors. So DPP-4, is an enzyme which then inactivates our endogenous GLP-1s, and DPP-4 inhibitors prevents this process from occurring. Otherwise, the half-life of GLP-1s would be about 2 minutes. So other than the organs I've discussed, it also affects the brain to increase satiety and reduce energy intake, and also affects the cardiovascular system, decreases systolic blood pressure and increases heart rate. So the other way in which GLP-1 receptor agonists are very helpful is that it causes a decrease in gastric emptying, and this gives rise to the common side effects that we see of nausea, vomiting, and abdominal pain. And this eventually leads to a decrease in appetite and the added benefit of weight loss. So this is the comparison of DPP-4 inhibitors versus GLP-1 receptor agonists and its effect on the GLP-1 concentrations in the body. So you could see that the GLP-1s have a much greater effect compared to DPP-4 inhibitors. This is basically a summary slide to show that semaglutide and dulaglutide are superior to the other GLP-1 receptor agonists, and comparing semaglutide to dulaglutide, semaglutide is better at A1C lowering. The leader trial compared liraglutide to placebo, and they basically looked at the outcome of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke, and they found that the primary outcome occurred at a lower rate in the liraglutide group compared to placebo, and this was largely due to a decrease in death from cardiovascular causes. The SUSTAIN 6 trial compared placebo to semaglutide 0.5 or 1 milligram, and the primary outcome was the same as the leader trial, and they found that semaglutide, the primary outcome occurred 26% less in the semaglutide group. This lower risk was primarily due to a decrease in the rate of non-fatal strokes, which occurred 39% less in the semaglutide group, and a non-significant decrease of 26% in non-fatal myocardial infarctions. There was no significant difference in the rate of cardiovascular death in this trial. So this is just a summary slide to show that there's some potential modes of actions available for GLP-1 and its impact on the cardiovascular disease. And what they think is that given that GLP-1s affect multiple organs, including the heart, vessels, and the immune system, the GLP-1 receptor agonists actually do stabilize, there's some various experimental data in preclinical models of atherosclerosis, which have shown that GLP-1 receptor agonists reduce atherosclerotic lesion development and progression by leading to more stabilized, less vulnerable plaques. And this is thought to be mostly due to the anti-atherogenic and anti-inflammatory effects in endothelial cells, inflammatory cells, which all express GLP-1 receptors. But the overall effect, beneficial effect of GLP-1 receptor agonists is thought to be multifactorial and a combination of metabolic, vascular, and inflammatory effects. GLP-1 receptor agonists also have an effect on non-alcoholic metabolic liver disease by a reduction in weight loss, by an increase in weight loss, which ultimately cause a decrease in intrahepatic lipids, which then causes reduced fibrosis and inflammation. So the adverse effects, I've already discussed the gastrointestinal side effects. Just in line with that, it's important to check whether the patient tolerated lower doses, because then you could try dose lowering and seeing whether they can tolerate it there. Otherwise, if it's obviously severe enough, you just have to stop it and consider other options for these patients. Pancreatitis has also been reported in association with GLP-1 receptor agonists, but there's insufficient data to know whether there's a causal relationship. But anyone who's had a previous history of pancreatitis, we say to avoid GLP-1 receptor agonists. So in terms of retinopathy as well, it's unclear whether the progression of retinopathy is a direct drug effect or as a consequence of rapid glycemic control. So what we say is that patients should have a recent optometry review prior to commencing semaglutide, so at least within the last 1 year prior to starting. So going back to our second case, so this patient basically was commenced on semaglutide in September 21, and then about 9 months later, when he had already commenced light and easy diet and reduced snacking, his HbA1c was 6.1% and his weight was 128 kilograms. So he lost 20 kilograms on semaglutide. Unfortunately, there was a semaglutide shortage which occurred, which I'm sure everyone's heard about in the news. And this was largely due to the fact that semaglutide was being used off-label for obesity management. This is just a snippet from Canberra Times, a TikTok user boasting about the good outcomes she had with semaglutide. But we have since heard that semaglutide is coming back in stock and should be available now, and the shortage should no longer be in place from April. So following the shortage of semaglutide, approximately 6 months later, the weight for this patient increased back up to 135 kilograms, and the HbA1c also increased to 6.9%. So on the note of obesity management, just quickly, semaglutide 0.25 milligrams to 1 milligram weekly should be kept for the patients with type 2 diabetes, especially with the shortages at the moment. There is liraglutide available for patients for obesity management, and later this year there will be a higher dose of semaglutide, 2.4 milligram weekly, available for weight loss, and this will be sold under a different brand name. So just to tie everything together, I think this is the current algorithm that we use, and it's published by the Australian Diabetes Society. It's important to recognise that this is very different to what it was even just 10 years ago, where I've been told my consultants basically had metformin for patients if they were overweight, sulfonylurea if they weren't, and then addition of insulin if they still weren't meeting glycemic targets. Now we have so many more things available at hand to us, and this algorithm helps everyone to better sort of guide their therapy. So first line therapy still is metformin. We basically almost never use sulfonylurea first line therapy. Insulin is still there if the patient has severe hyperglycemia with a very elevated HbA1c. Second line, straight away you can use SGLT2 inhibitors or a GLP-1 receptor agonist, and there's very helpful icons there with heart and kidney to help guide your therapy depending on the comorbidities that your patient might have. So and then of course you still have your sulfonylurea and insulin still there. So coming back to the two cases we spoke about, both of these cases were able to initiate lifestyle modifications with significant changes in their weight and their HbA1c. But one
really about levofloxacin and withholding it. So obviously fantastic drugs, but they cause us a lot of trouble in our world. I notice in your recommendation you talk about stopping for 3 days, which is what we do, but often we find even after 3 days of cessation they can be ketotic. And we assume that's probably because they're fasting and dry rather than being affected with fluxing itself. So my question is there any harm stopping for longer? Why not just stop the drug for a whole week? Because it's a long-term gain, isn't it? It's not a short-term fix. And if you stopped it for 7 days, would there be any need to actually check for ketosis at all? Because if it was present, it would be through other mechanisms such as starvation rather than the effect of the drug.
I don't mind.
I was going to say, I'm going to blame what you do to the patients in your bowel prep process is a large part of the problem that causes the ketones in addition to the SGLT2 inhibitor. So you're right, I've got a number of patients who, when they're doing bowel prep, I actually get them to stop earlier and 3 days before you start messing with their diet and doing other things that are going to generate ketones, because I think the risk does become much higher. But if it's for a standard surgical procedure, generally 3 days is adequate. But if you have any other reasons for concern, if they've had any problems previously with ketoacidosis, but someone's been brave enough to put them back on, then certainly withholding for longer isn't a problem. And there's no necessary reason to check the ketones if they have a normal glucose level, they feel well, they have no other symptoms of ketoacidosis, and you have no other great reason for concern. Don't know if any other endocrinologists in the room do something different, but that's my approach.
Just on that question, so before we move on to the next topic, so obviously patients coming into hospital usually are sick for some reason, and in your slide you talk about withholding if there's an illness. I guess what is this threshold, given most patients have got some reason to be in hospital rather than being managed at home, and they're hemodynamically compromised, or they might have sepsis, or they might have any number of things. And a lot of these patients are on these drugs.
Yeah.
We're not routinely seeing them being withheld. Should we be?
My intern teaching tells them they should be.
So,
Yeah,
so
absolutely. We should be. In
yeah.
an acute and current illness, if they're sick enough to be in hospital from something that is actively medically causing them problems, then yes, you should withhold them.
Yeah.
I think what we saw when these drugs came out was that the rates of DKA in the studies were a lot less than what we saw in real life when we started using them in real people who got sick and had other things happen. And so I always tell my patients, if they're sick enough to take a day off work or lay up in bed, they should stop taking their SGLT2 inhibitor for that day. Professor Nolan may want to add.
Most patients in this hospital that have been quite sick, they're quite high risk. My advice is for the majority of patients.
And we can always manage the hypoglycemia in other ways as well.
Yeah, of course.
Another thing is very often telling them and using this stuff.
I think we've got pharmacy med recs happening early on in the piece now, both in emergency and on the wards, plus also our medical registrars. I think that message that's a good message from today, actually, to talk about it, given the prevalence of this medication being used.
Absolutely.
And then Ritoo's right. The other thing is that these drugs are often not recognised. So often we get a call, there's someone in ketoacidosis. Are they on SGLT2 inhibitor? No. Can you read me every single medication that they're on? And you tease out that they actually are. So it's a kind of
That's the too many acronyms.
Is there any to skip this open
Yeah, so especially like if you're worried about hypoglycemia, or if they have CKD, the risk of hypoglycemia is higher in this age group. So I would, yeah, definitely just, with the algorithm that I showed before, definitely go to a second line agent that's not sulfonylurea. I'll just bring it up.
Yeah, I actively avoid sulfonylurea use in the elderly. It gives them more risk of hypoglycemia than it does any great benefit. If you're trying to avoid injectables and other drugs that can also cause them risk, the use of a DPP4 inhibitor, something like linagliptin, where you don't have to dose adjust for renal impairment, is a really good choice in your patient population. And that's where I would often go with my outpatients who are older and don't need sort of really aggressive glycemic optimization.
Sorry, it's a follow-up question. Are you finding some of these new agents which was
Depends on the patient is going to be my comment. As you know, biological age and chronological age are so different. So it really does depend on the patient in front of you. Absolutely. I still don't tend to push for a particularly low A1C target in older patients as a rule. But, the risk of developing long-term complications is not really significant, but the risk of causing acute complications from hypoglycemia is much greater. So long as they're not symptomatic or at risk of symptomatic hypoglycemia, I still moderate targets. Still safer, but there's enough other things that can wobble, like renal function and so on in older age, that makes me still cautious.
Oh, yeah.
Is osteoporotic fractures. Most of them are definitely elderly, most of them have renal impairment, if not heart failure and so on. The new medications looks very well for heart failure and diabetes and definitely kidney failure, but not so good for the bones. Practically, if the patient has had, will you continue this medication or will you stop some?
That's a very good question. I guess, sorry. Given that,
Repeat the question for the people online.
What was it?
Oh,
There's a comment here, just if they could repeat the
oh,
question.
sorry. Do you mind just repeating the question with the mic?
And I think for you to repeat it.
Oh,
Yeah.
okay, sorry. The question was bone fragility fractures in the setting of SGLT2 inhibitors. Given that there is a lot of benefits from these medications, would we still consider it if someone were to come in with like a neck or femur fracture? I guess the studies that are done were only based on canagliflozin, and we don't use canagliflozin here. I don't know that the same sort of effect has been seen with other SGLT2 inhibitors, so we're not sure if this is a class effect or specific to just canagliflozin. And I guess with like the specific question about the neck or femur fracture, I guess if the patient was commenced on it for, heart failure with reduced ejection fraction or, CKD, I would potentially consider continuing it until there's better data available with regards to bone fragility fractures and this drug class. Yeah, I guess the other thing to mention would be as well, just to check whether that patient had postural hypotension with the SGLT2 inhibitor and potentially consider modifying the other medications they're on.
Sorry, but the SGLT2 inhibitors increase the PTH. So what will be your decision? What is the balance? If the patient has hypertension, has, let us say, renal failure, possibly not end stage, but still renal failure, 3-4 stage. Will you continue this medication if she has been prior to the fractures, or will you substitute with something else?
Sorry, was there a mention about the PTH? Did you say PTH?
The oil hormone is increasing, APT is increasing. This has been shown in a couple of special studies.
I think in the setting of, say, renal failure, for example, with hyperparathyroidism, does that impact your
Right, okay.
I mean, I think again, my comment would be again to individualize. It depends on the risk of the complications from the heart failure, what other medications they're on or can be used. Similarly for the renal failure, so it's very difficult to give you a one-stop answer. But if someone's got known osteoporosis, they were at risk of fracturing anyway, but this drug is going to provide them with other clinical benefits, then I would be comfortable in continuing it, because I think that the risk of the contribution from the SGLT2 inhibitor is not. It's not going to be your top or only contributor, but it does depend on those other scenarios and really what you're trying to balance out. And I guess that's where we can talk about the class effects, but the nuances of the patient, it's hard to give a sort of a solid answer, but I would be comfortable using SGLT2 inhibitors in patients with osteoporosis, even with fragility fractures.
Well, it looks appropriate, but let us take an example.
Do we have time for example,
Alex, we might need to take this one offline, just because we're running out of time. Does everyone have any last minute questions or comments, Chris?
I just might make one comment about
Yes.
the elderly with the SGLT2 inhibitors. If you've got a patient that's sitting there at a bed and you've got to encourage them to drink, it's not a drug for them, the same high risk of dehydration, hypertension, etc. So the frail patients, I think the risk of falls is probably relevant there. And it's weighing up all these critical things. What I might add to this whole discussion, thank you, Ritoo, for a really nice presentation, is that the ADS and in HMRC have this process of living evidence guidelines for management of type 2 diabetes, and I'm looking at the moment about the best second-line agent reviewing the data, and they look at all the huge number of clinical trials that come into a big database, huge analysis, and for the majority of type 2 patients, particularly at high risk of heart failure, renal disease, and cardiovascular, the SGLT2 inhibitors are probably top of the list, above GLP-1 receptor agonists, except for stroke. For patients at risk of having stroke, there's sort of mutual benefit from SGLT2, and there's some studies that suggest maybe some risk. to make a GLP-1 receptor agonist for people with stroke. With prevention of heart complex complications other than heart failure, there's not much difference between GLP-1 receptor agonists and SGLT2 inhibitors for heart failure. SGLT2 inhibitors are better, preventing renal progression. SGLT2 inhibitors. So it's weighing up lots of things for the individual patient.
Thank you, Chris. We might wrap it up there. Thank you, Ritoo, for that fantastic presentation. It is becoming a crowded field and slightly complicated. And I think if Professor Nolan, you are on a guideline committee, if you could work on the acronyms to make it a little bit, make them make sense, so we can remember these classes a bit better, that would be great. But thank you very much. Obviously, the endocrinology department here to help us make these decisions too. But these education sessions are really important. Can we just put our hand together for Ritoo?